Sir, we are live now. With all your permission, I am starting this
Yes.
session.
Yes.
Yes, sir. Thank you. Good afternoon, everyone present here. I am Faraz from IJCP. Welcome all the participants on today's webinar. Let's welcome today's speaker, doctor with great honor, none other than Dr. M. Bala Subramaniam, sir. And let me share some of the achievement of sir. Sir has done MD, DV, graduated and post-graduated from Madras Medical College, former State Secretary, President and National Vice President of IMA, Founder Secretary and past Chairman of Professional Protection Scheme IMA Tamil Nadu. And today sir is going to discuss on a topic Syndromic Management of STD. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you, Mr. Faras, and yet another thanks to IJCP for giving me another opportunity to speak with you all. Today, I am going to discuss syndromic management of sexually transmitted disease. Many doctors may think STD is a minor problem. The diseases are few in number, easy to treat. Why we should have syndromic management? Only when it is complicated or difficult to treat, we should have a syndromic management. When the diagnosis is simple and straight, why we should have a syndromic management? But this syndromic management has been put forth by World Health Organization and Center for Disease Control in states, taking into account the sexually transmitted diseases are prevalent for many centuries and they are increasing in number, especially among the vulnerable groups. And this sexually transmitted disease spreads HIV in a faster way. Presence of sexually transmitted disease increases both getting and transmitting HIV. So if you want to control HIV or AIDS, first we have to control sexually transmitted diseases. And with this only, they had suggested syndromic management of STD. Let me quote few examples. Case study 1, a 19-year-old male came to the family doctor after sexual exposure with multiple pinhead projections over corona glandis. He had sexual exposure with his wife only, that too after the marriage. And after the first exposure, he thought he has developed sexually transmitted disease. He thought he has got warts. We always say, even the darkness can present like a devil in a disturbed individual. So, one minute. Right. So he went to a general practitioner and he concurred that it may be warts. So he referred the patient to a venereologist or a dermatovenereologist, saying that he is referring a case of warts for favor of applying podophyllin or laser treatment. The venereologist they saw and said what he had is not warts. It is only polypenile papules or ectopic sebaceous glands or Fordyce glands. He assured 20 to 30% of the people, male adults, will have this um, uh, polypenile papules or Fordyce glands, and it is nothing to worry about, nothing to treat. What we have to observe is only genital hygiene. In fact, nowadays we have condoms, not just plain condoms. We have dotted condom, spotted condom, spiked condom like that to give more pleasure to the female partner. And hence, this person with polypenile papules will be giving more pleasure to the female partner. So he need not be worried. Yes, indeed, he should be thankful to the Almighty. A newly married girl went to a lady doctor with 2 months of amenorrhea. Nowadays, the ladies get married at a late age, after 25, 28, like that. And they want to become pregnant within a year of getting married. The pregnancy was confirmed by urine grav index, which the lady herself got the kit from pharmacy and tested herself, and she felt it was positive. So he went to a lady doctor, and usually we do all these tests during the first visit of any antenatal case: hemoglobin, blood group, RH, blood sugar, VDRL, and now we do HIV also. So the blood VDR report came as reactive in two dilution. So the gynecologist or the obstetrician said, what is your husband doing? He's a sales representative. Does he go outside the house or outside the town often? Yes, he undertakes a lot of tour. So both of you please go to a dermatovenerologist or a venerologist like me and get the opinion, get the treatment, and then come back. They came to us, and we, seeing this report, we did the VDRL for the husband, and it came as non-reactive. And the husband suspected the wife. Now, you suspected me. Now, I am non-reactive, you are only reactive, like that. They were quarreling in front of the doctor. And we assured the couple, and we did the blood TPHA, Trypanosoma pallidum hemagglutination test. It came as non-reactive. We assured that this VDRL can become reactive even in non-syphilitic patients because the antigen prepared for the VDRL is from the bullock heart muscle added with lecithin and cholesterol. So we will do a specific test. It is only a sensitive test, but we have to do a specific test called Trypanosoma pallidum hemagglutination or TPHA, or we have another test called FTABS or TPI, where the antigen used is Trypanosoma pallidum. So we told them that it is only a biological false positive. Any VDL report less than 8 dilution, we have to remember false positive can occur. So we have to do specific tests. A 45-year-old male came to a family doctor with symptoms of anxiety. He complained of burning sensation over the genitalia at the start of the intercourse itself. He opined that his wife has become more hot. The general practitioner examined, and he found nothing, and just reassured these are all with the mind only. There can be few secretions which are normal in the women, and because of this irritation, you may be having some funny sensation like that. But 3 months later, patient came again with painful fissures all over the prepuce. Prepuce were sodden, dirty white in color, and longitudinal fissures were there. The patient was referred to a venerologist or dermatovenerologist, and patient asked the doctor asked the patient whether he is diabetic. He said, "No, sir, I don't have any symptoms of diabetes. Polyuria, polydipsia, polyphagia, like that. All ulcers heal, any wounds heals nicely. But anyway, do the blood glucose random. It came as 330 milligram percent. So the doctor said, well, you have diabetes mellitus now. Whenever the blood sugar is more than 180, it will come in the urine as sugar, and when it touches the prepuce, the candida albicans, which is there in the mouth to anus of the patient, all people, they can reach this prepuce, especially while washing after defecation and other things, and sit on the prepuce and produce this candidal balanoposthitis. So this candidal balanoposthitis may be the first presenting symptom of diabetes, presenting sign of diabetes mellitus. Erectile dysfunction is the first presenting symptom of diabetes mellitus. A 63-year-old man went to a doctor in Tirupati in Tamil Nadu with proliferative foul swelling and bleeding swelling over the entire glans penis. The doctor did not palpate or elicit history. He referred him to Stanley Hospital as carcinoma penis for favor of partial amputation of penis. So 3 weeks or 1 month later, this patient returned back to Tirupati. Doctor was very curious how much of penis has been chopped off. So when he came to him, he examined him and he was excited or surprised to see the entire penis intact. The patient told, you referred me to cancer OP, but they referred to STD OP. And they took the STD that I had, even though my wife is as expert, I had contact with another lady for a few months. So I had developed this, and what they said was the patient that I am having venereal granuloma, and they gave me 2 weeks of doxycycline, and entire ulcer healed, and they did not chop off any part of the penis. So passions do change with time. Radio diagnosis, when I did postgraduate thing, venereology and radio diagnosis were the least sought after branches among the fresh graduates. But now radio diagnosis after ultrasound, CT scan, MRI, so many procedures being done with scan, ultrasound aided procedures, CT scan aided procedures. So now the NEET topper prefers radio diagnosis. He can sit in the AC room or AC console room and give you his opinion and get a lump sum salary. And same way anesthesia. After super specialty surgeries and intensive care unit with ventilators, anesthesia has become a hot branch to take up. Same way venereology after HIV/AIDS, and that too after sildenafil. So sexual medicine as such being more linked to venereology rather than obstetrics, urology, psychiatry, like that. So this venereology, dermatovenerology has also become a hot branch for the NEET toppers. So it is like a wheel, which is any branch which is down, in another 10, 15 years, it will come to the top. So this venereal disease has derived its term from Venus, the Roman goddess of love. So does it mean that those who love will get the disease? No. Those who fall a prey to lust and who are promiscuous, especially they do not bother about the partner, place, or time. They have sex, unprotected sex, and these people get the disease. So the name was changed to sexually transmitted diseases. For a thing to be called as disease, we should have signs and symptoms. Here, in syphilis, HIV, hepatitis B, something, so many other diseases, we do not have signs and symptoms, but they harbor the virus and they are infectious. So the term was changed to sexually transmitted infections. And the obstetrician and gynecologist to whom many of the patients, especially the lady patients, went, they were not willing to use a term called sexually STA, and they suggested RTA, reproductive tract infection, like urinary tract infection, upper respiratory tract infection, like that. So reproductive tract infection has been made. So up to 2003, venereology and dermatology were separate, especially in Tamil Nadu and Andhra Pradesh, where with MC instruction, they were combined from 2003. It is even in Tamil Nadu and Andhra Pradesh, it is dermatovenerology. So whether venerology has become a subspecialty or super specialty, only the time has to tell. So this is a definition. DASH is an infectious disease, systemic from the onset, capable of involving each and every structure in the body, characterized by florid manifestation on one hand and periods of complete latency on the other, can mimic many diseases in the field of medicine and surgery, transmissible to the offspring, transmissible to certain laboratory animals, and treatable to the point of presumptive cure. So this was a definition about 100 years back given by Stokes for syphilis. Hmm? Uh, in fact, blood transfusion was not there during Stokes period. Had it been there, he would have included transmissible by blood transfusion, unscreened blood transfusion also. So syphilis was in the differential diagnosis for all branches of medicine and surgery, like gamma, aneurysm of aorta, aortic incompetence, tabes dorsalis, GPA, like that. All the things were in the differential diagnosis. So one of the tests done for all the inpatient was VDR. So relationship between syphilis and HIV. HIV is yet another sexually transmitted disease. Both of them have the same risk behavior, and wherever sexually transmitted disease were rampant, now HIV is also very much prevalent there. Sex is the predominant mode of transmission, same risk behavior. Measures of prevention are the same. STD clinics provide important access point for HIV patient. If we come across 0.25 to 0.5 of HIV in the normal population, here it is more than 5 to 10% of the STD patient, HIV in the STD patients. Trend can be good indication of sexual behavior. STD trend can be a good indication for sexual behavior. Control of sexually transmitted disease, control of thing. And STD facilitates the acquisition and the transmission of sexually transmitted disease. And let me tell a small thing. See, two friends who are in the early 20s, they went to a commercial sex worker. One of them had genital ulcer. The other person did not have genital ulcer. Both of them had sex with a HIV positive commercial sex worker. Whom do you think would have been affected more? Thing. You may tell it may be the opening batsman. First person who went to that lady would have got and sucked all the viruses from her vagina like that. No. Person with genital ulcer is more prone because the HIV is not a motile organism. It cannot jump from one place to another. But all genital ulcers, they go for natural healing with helper T4 helper cells, which are the target cells for HIV. So, in the ulcer side, target cells are available in plenty. So, any HIV in the vagina of the thing will stick on to this target cell. And once enters into the target cell, many times it may not be possible to kill the virus. Right. Next one is two boys were there. They had different girlfriends. Both of them were HIV positive. One was they had genital ulcer in addition. Who would have been the unfortunate lady, girlfriend who would have got this HIV? Here, the person with genital ulcer and HIV positive is more prone to give the thing because I told you the T helper cells, along with healthy T helper cells, the infected T4 helper cells would also be there in the ulcer side, and they would burst periodically, and all the serosanguinous fluid in the ulcer side will be full of HIV particles, and the viral load will be very, very heavy. So the girl who has unprotected sex with a HIV positive boyfriend with genital ulcer is more prone to get HIV. So let me see a few of the sexually transmitted things. This is a single painless indurated ulcer with painless lymphadenopathy. This is primary syphilis or chancre. These are grayish, flat-topped, moist lesions occurring at the mucocutaneous junctions. These are condylomata lata of the secondary syphilis, which will be teeming with Treponema pallida. So the most infectious lesion in syphilis is condyloma lata. This is a purulent discharge from the urethra. This is gonorrhea. These are multiple painful ulcers of chancroid. These chancroid, they cause outer amputation of phagedenic type of chancroid, especially with fusospirochetes, especially if the patient is phimosis. These phagedenic can cause auto circumcision. These are warts. Well, the difference between skin wart and genital warts is genital warts, they are non-keratinized. So we can see the blood vessels, reddish blood vessels through the top layer. And so the treatment also is different. In common skin wart, we use keratolytic agents. Here, keratolytic agents are not necessary. Only we require antimitotic and cytotoxic drugs like podophyllin. This is warts in a female. And these warts will increase in size during pregnancy because of diminished immunity, more vasculature, more moisture. So warts will increase huge in size. Here, podophyllin application is contraindicated. We cannot conduct normal delivery because it may cause laryngeal papilloma in the newborn. So cesarean should be done before rupture of membranes. These are grouped vesicles, herpes. They may rupture to form multiple ulcers and they may join together to form a single ulcer with a polycyclic border. Anything appearing to start as vesicles, we have to suspect herpes. This is venereal gramma. Even though it is single, you can see it is more soft and it is almost started bleeding. So any soft granulomatous ulcer, we have to suspect venereal granuloma. This is also venereal granuloma where the ulcer, the causative organs are spread subcutaneously and cause the groin ulcers. So that is why it is called granuloma inguinal. Here the lymph node above and below the inguinal ligament, they are enlarged. This is lymphogranuloma venereum. Even though small ulcer may be there to start with, it would have disappeared or healed by the time PIBO appears. So the conditions are very, very few and simple and very straightforward and so easy diagnose. So the clinical approach is it is the time-honored, time-tested. It is simple and cost-effective, but but the limitations are poor presentation due to prior treatment. A person with gonorrhea might have taken a suboptimum antibiotic and the discharge may not be purulent, it may be mucopurulent, mimicking chlamydia. Or mixed infection. Both chancre and granuloma can occur in the same ulcer site. So, even though clinical approach is easy and simple, we undertake certain diagnostic uh, things. The benefit is makes the diagnosis accurate, so we can use a single drug to treat the single condition. Whereas the limitation is we require need equipments and expertise, and it is time consuming. Patient will come today, we will take the smear or say serological test, ask him to come after 2 days or one day. He may not come at all. Default is highly noted among the sexually transmitted disease patients. So it is better to treat the patient when he comes for the first time itself. So the third approach is syndromic approach. This is not unscientific. We cannot call it as polypharmacy or shotgun method. And it is not new. You see, in India, when the patient load is heavy, in a busy OP, doctor sees more than 100 patients in 2 to 3 hours. So he puts the diagnosis of all fever as PEO, all who sneezes as URI, all who causes as coughs LRI, burning micturition UTI, and any diarrheal disease in ADT and acute diarrheal disease, and gives the treatment. And when they come for follow-up, then they concentrate on the pathophysiology of the presentation. And so it is no disgrace is that the patient gets the relief immediately, and it is the need of the hour, especially in the era of HIV. So in syndromic management, the benefits are because this is simple, there is no misdiagnosis. A person comes with ulcer, you put the diagnosis as GUD, genital ulcer disease. If a person comes with urethral discharge, you put not to bother about gonorrhea, chlamydia, put urethral discharge like that. And no ineffective treatment. We treat both the conditions or the three conditions which cause the disease. So there is no ineffective treatment at all. Single visit is sufficient. And there is no waiting period. And there is no social stigma because we put the diagnosis as broadly as RTA, reproductive tract infection, or specifically as GUD or UD like that. And it is cost effective in the sense we save a lot on the laboratory investigations. But the limitation is follow-up is difficult. There may be overdose and wasting of drugs. Asymptomatic people escape. Poor correlation between STD and non-STD. So we have a flow chart. The WHO and CDC and our NACO has given this flow chart. So in the case of genital ulcer, take relevant history and examine. No ulcer or vesicles, just reassure the patient that he is not having a STD. If the vesicles intact, broken, history of recurrence is there, then we put the diagnosis of genital herpes and advocate genital hygiene, acyclovir 200 milligram orally, 5 times daily for 7 days, treat partner and promote condom. Genital ulcer present may have swollen lymph nodes, yes. Then we have to give benzathine penicillin, 24 lakhs IM after test dose. Or doxycycline, person is allergic or you are afraid to use benzathine, you have to use doxycycline 100 milligram BD for 14 days or erythromycin 500 milligram QID for 14 days in pregnant women. We have to use erythromycin steroid, not estrogen. So for genital discharge, take relevant history and examine, milk the urethra, discharge. If it is not there, re-evaluate, educate on safe sex. If the discharge is there, injection ceftriaxone 250 milligram IM or azithromycin 2 grams. and tinidazole 2 grams stratum. Or doxy 100 milligram BD for 7 days. Or doxy 100 milligram and treat the partner and promote condom. In pregnant and lactating women, avoid azithromycin and doxycycline. Instead, use erythromycin 500 milligram QID for 7 days. Avoid tinidazole in the first trimester of pregnancy. So this is the flow chart. It is there for all the other conditions like vaginal discharge. Vaginal discharge where speculum is there. Lower abdominal pain. It is not labor abdominal. Lower abdominal pain in female. Inguinal prebo. Painful scrotal swelling. Epididymoarthritis. Neonatal conjunctivitis. So this is a flow chart where even a non-medical or a paramedical person just can monitor and give the treatment. This is done in African countries where the number of doctors and nurses are few in number. So I have promoted my own style of syndromic management by quoting the 7 wonders in sexually transmitted disease. The first wonder is the pyramid, where it is in the desert. We have to travel a long distance in a camel, and even on nearing the pyramid, many of us will not be brave enough to enter because of certain fear of evil spirits in the pyramid. So, when a STD patient comes, just receive him like any other patient, listen to his complaint, and examine him, especially the genitalia, whether he has got ulcer, discharge, or pubo, and give the treatment. So you just have to receive like any other patient, and just aerial look is sufficient. You need not even put the gloves and palpate. This is the Eiffel Tower of Paris, where the teenage boys getting the early morning erection or seeing nude photograph or certain of his girlfriend, they notice the erection. They will not discuss with parents or teachers. They may discuss with the friends, peer group. That is why we tell your friend who is your friend, I'll tell you who you are. So these friends may be misguided or misled, and they may be taken to some of the commercial sex workers and have sex, and they may come with genital ulcer. Genital ulcer, we have two: genital ulcer, non-herpetic and herpetic. If it starts as vesicles, it is herpetic. Genital ulcer, single or multiple, painful or painless, burning sensation in genital area, enlarged lymph nodes. So we have the ready-made kit available, supplied by the NACO. Benzathine penicillin 2.4 megaunit, that is 24 lakhs unit, and azithromycin 1 gram single dose for venereal granuloma. See, in the Institute of Venereology, Government General Hospital attached to Madras Medical College, we never had a death due to benzathine penicillin anaphylaxis, especially when we give after test dose, where we add 6 ml of distilled water and take about 0.1 ml, dilute further with 0.3 ml. So the give 0.1 ml as the skin test dose. We are giving only 5,000 to 10,000 units of penicillin. So when the local person with penicillin anaphylaxis, they will first develop local reactions. And if you give the remedial drugs like adrenaline, Decadron, IV fluids if necessary, you can prevent severe anaphylaxis and withhold the things. That will be one thing. So we never had a death due to benzathine penicillin. That's it. Or the patient is allergic to penicillin, then we give doxycycline 100 milligram BD for 15 days. 30 capsules will be there. Or azithromycin 1 gram single dose. Genital ulcer with vesicles, single or multiple painful burning sensation in the genital area. Then we have to treat it as genital herpes, acyclovir, 400 milligram TDS for 7 days. So I told you 200 milligram 5 times daily for 7 days. But for patients' complaint sake and convenience sake, we give acyclovir 400 milligram TDS for 1 week. This is slanting tower of Pisa. The person with gonorrhea or chlamydia, they will have anti-urethritis, and this will cause partial erection in them always, thinking that they have become more potent. They may expose themselves again and again and spread the infection. So, in a case of urethral discharge in male, pus or mucopurulent, pain or burning while passing urine, increased frequency of urination, systemic symptoms like malaise, fever. We have to give azithromycin 1 gram to take care of chlamydia and cefixime 400 milligram to take care of gonorrhea. This is the Taj Mahal, which is built out of marble. It is not white, it is grayish white or yellowish white. So in women with white discharge, nature and type of discharge, quantity, color, odor, burning while passing urine, increased frequency, genital complaints by sexual partners, low backache. So, so she has got vaginitis. So we can give secnidazole 2 grams to take care of trichomonas and also bacterial vaginosis, and 2 capsules of fluconazole 150 milligram to take care of candida. So only thing is we have to ensure that cervix not inflamed and there is no discharge from the cervix. Only from the posterior fornix of the vagina it is there. So vaginitis due to trichomoniasis, bacterial vaginosis or candidiasis can be treated with secnidazole 2 grams and fluconazole 150 milligrams later. If there is cervicitis, then we have to think of gonorrhea and chlamydia, and especially when it ascends up and causes lower abdominal pain, vaginal discharge, menstrual irregularities, dysmenorrhea, dyspareunia, dysuria, tenesmus, lower backache, cervical motion sickness. We have to give cefixime 400 milligram OD statum, metronidazole 400 milligram BD for 14 days, doxycycline 100 milligram BD for 14 days. So cefixime will take care of Neisseria gonorrhea, doxycycline on chlamydia, and metronidazole on anaerobic organisms. This is a Great Wall of China. To me, it looks like inguinal ligaments from symphysis pubis to ischial thing. So here in pubo, swelling in inguinal region which may be painful, preceding history of genital ulcer or discharge, systemic symptoms like malaise, fever. So it may be due to LGV or chancroid. We give azithromycin 1 gram OD plus doxycycline 100 milligram BD for 21 days for pubo. This is a hanging garden of Babylon. In male, there is scrotum hanging merrily with testes, epididymis, and pars deferens within it. So in the case of epididymoarthritis, swelling and pain in the scrotal region, pain and burning while passing urine, systemic symptoms like malaise, fever, history of urethral discharge. Here we have to give azithromycin 1 gram statum, cefixime 400 milligram statum. This will take care of gonococcal epididymoarthritis or chlamydial epididymoarthritis and give the relief. So This is a simple thing where it can be followed even in sub centers or primary health center. But you have facilities for laboratory diagnosis, for STI management. If you have basic on-site laboratory, we can thorough physical examination with complementary laboratory procedures, and we can give a quality STI things. So this we teach to all the medical officers in the primary health centers and taluk hospitals. These are the gram stain, KOH for Candida, vaginal pH, RPR, TPHA. Here, we have to remember that we have to treat the partner. Primary contact is the one from whom the person got the disease, and secondary contact is one to whom he has given the disease. So we give the treatment, both primary and secondary contact. We call it as epidose treatment, and we always give a full dose. It is just because they do not have any signs and symptoms, we should not give a reduced dose. We have to give the same full dose. So I told you STD-OP may be the place where we come across HIV patient thing. So 10% of the STD patient, they have HIV. Same way, chest disease OP, 10% of the TB patient may have HIV, or 10% of HIV patient will have TB. So these are the places where we can suspect and pick up HIV cases. When to suspect HIV? We know this is scabies. Common diseases not responding to accepted line of management, not responding to one application of gamma benzene or two application of benzyl benzoate, then we have to suspect HIV. Common diseases not responding to accepted line of management. This is molluscum contagiosum. This is herpes zoster. If they occur, herpes zoster multidomitom and molluscum contagiosum in a sexually active person, unusual presentation of common diseases. So these diseases we often see in the children. So unusual presentation of common illness, you should make you to suspect HIV. This is the purple spots body, which many of us would not have seen. This is Kaposi sarcoma. Unusual illness in uncommon individuals, we have to suspect HIV. Well, so this is a mouth with multiple things: oral hairy leukoplakia, gingivitis, caries tooth, aphthous ulcers, all occurring inside the mouth. This is TB, PCP, TB, and effusion occurring in the same lung. More than one disease in a single organ, we have to suspect HIV. More than one disease in a single organ. This is candidacy of the tongue, candidacy of hot palate, soft palate, candidacy of the esophagus. Single disease in more than one organ. Say pulmonary tuberculosis, TB abdomen, TB skin, all occurring in one individual, we have to suspect HIV. So we have to do the blood test only after pre-test counseling and informed consent. Spot test for HIV, ELISA for HIV, not disease CD4 count, ART. We have to use 3 drugs lifelong. So these people get the disease because of their risky behavior. So it is our duty not only to treat, but also do counseling and educate them. So A is for abstinence before marriage. Abstaining from sexual activity, that is penetrative sex before marriage, if they abstain themselves. Friendship should not cross boundaries at any time. We have to teach the teenage people and other youngsters as a premarital counseling. Married partners, marital relationship should be mutual, trusted, and long lasting. So B is for be faithful to the marital partner. A for abstinence, B for be faithful. For those who cannot listen to A and B, we suggest C. Never condom condom. They should have casual sex only with condom. So even if they get the disease, we can assure them D for drugs. If they come after exposure, get the syndromic management of sexually transmitted disease, or ART if they get HIV, is there. So D for drugs. Caution. Any individual indulging in indiscriminate, unprotected sex will eventually end only in misery. And any country ignoring HIV or STD is only behaving childish and virtually land up in severe political, social, economical, medical disaster. Even India, we thought we are all people with good cultures and other things, and homosexuality is not there, IV drug abuse is not here, and like that. But we found that we came into red category within few years of HIV being reported. So, just like our late Abdul Kalam, we have to teach young boys and girls on good touch and bad touch, and teenagers on prevention of sexually transmitted diseases.
Thank you so
That's
much,
it.
sir, for giving out your valuable time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants, sir, who have joined these sessions. Sir, I have received some questions, sir. If you allow, with all your permission, shall we take these questions?
Yeah, please.
Yes, sir. The first question I can see is from Dr. Agarwal. He is asking, how do we address issue of patient confidentially and stigma associated with STD syndromes when providing syndromic management services?
Yes. See, the STD patient may come along with other patients in the general queue itself. He may not come to the special department directly many times, or to general practitioners like that. Here, the patient first will hesitate to tell his complaint. You will pull the stool very nearer to the doctor, lean forward towards the doctor, and tell in a whispering voice that he has got a problem, private problem like that. He will take some time to tell his problem itself. So we have to be patient with the patient and find, and in all probabilities, you will have come out and will say that he has got ulcer, discharge, like that. Once the patient tells that he has got a venereal disease, many of the general practitioners or in the general OP, they get annoyed because they are not comfortable in treating sexually transmitted diseases. So they they will ask him to get back, or the doctor will go back and he will try to wear gloves, ask for gloves like that, and make the presence of the patient still worse. So we need not get annoyed. Only if you know about the syndromic management, what is required, it is only patient hearing, eyes confirming the diagnosis and treating by syndromic things. And there need not be any stigma attached to it. Well, see, we are not here to judge the character of the patient. Even if immoral person or something person comes with exposure outside, we need not get anger and other things. Our duty is to treat. See, even when a person who has committed a crime, say even a murder, if he comes injured or during the fight or try to kill, we always feel mercy with the patient. Even though he has committed a murder, we treat the patient. For us, the patient is the first person. It is our duty to treat. Same way, this innocent person, without being aware of the things, he has exposed himself. And it is not that all the 100 people who have sex outside get the disease. He is unfortunate. He is one among the 1 to 10% of the persons who get the disease on a exposure outside the marriage or before marriage. So 90 people, they have got scot-free. The society, these 90 people are still there. There are those who had casual contact and other things. So we should feel pity for him, feel empathy for him, and treat. So there should not be any stigmatization. Examination should be done in privacy. Confidentiality should be best assured. We always put the diagnosis as RTA or GUD and give the treatment. And whatever drugs we use, no, they are not special drugs. If I use INH rifampicin, the pharmacist will know that I am treating a case of TB. Whereas here, when I give doxycycline or azithromycin, he cannot, even if the tablets are there in the purse or the bag, nobody can suspect the person has got STD or HIV. So these are not, HIV has got special drugs, we have to accept it. And many of them they get from the government side because this is costly. So they go to monthly once, get the antiretroviral drugs. There are good counselors in the ART centers, so it is that. So it is our duty, especially in the era of HIV, we have to, and to prevent the innocent wife getting the disease, better treat him at the earliest, if necessary, treat the partner.
Thank you so much, sir, for explaining it really well, sir. I hope this will be helpful to all the audience who are listening to this. Sir, another question I'm taking, sir. What are the implication of emerging trends such as antibacterial resistance and changes in sexual behavior on syndromic management strategies for STDs?
Yeah. See, bacterial drug resistance, they are occurring there, especially in gonorrhea. Gonorrhea, when sulfadizine was introduced, with just 2 tablets of sulfadizine was sufficient. Then we had cotrimoxazole was there. Orizol, Matribond, they were there, long-acting sulfurs. They were sufficient. The gonorrhea became resistant. And we started with the ampicillin. We went up to 3.5 grams of ampicillin, single dose. So they have become resistant. So we added this Benamid to prolong the action of penicillin. Even that did not work. Then we had so many other drugs, doxycycline, erythromycin. Now we have come to cefixime. Cefixime 400 milligram. See, the pity is that no new antibiotics have been discovered or prepared in the last 5 years. Or now we can even take last 10 years. We do not have a new antibiotic with us. All antibiotics are getting resistant. Even in respiratory infections, pneumococcal infections. So we are using the highest sulbactam, and other things. We don't have drugs further than this. Even in TB, we have got resistant, rifampicin resistant, multi-drug resistance is there. So we have only few options now. So it is always use the drugs whenever necessary and use it in the optimum dose and use it for the optimum time. So abuse of antibiotic should be discouraged.
Thank you so much, sir, once again, sir, for sharing your insight on this question, sir. I will be taking one last question for today's session from the participant. His name is Subramanyam, and he's asking, are there specific populations such as pregnant women, adolescent, or men who have sex with men, are for whom syndromic management approach need to be tailored, sir?
Hmm. See, we call them as risk groups, and similar to syndromic management, we have presumptive treatment. We presume that these people with a risky behavior, that is, males having sex with male, so these people are more likely to get the disease. So for them, we use preventive treatment. Presume that they have got disease, so we give them monthly once or once in 3 months. We bring them to the thing or treat or give the same syndromic management, both for ulcer and male. For ulcer and discharge, we give simultaneously to them. So this is called as presumptive treatment. And this one MSM is gradually surfacing out. Surfacing out in the sense that they are bold enough to come as a thing and present to the doctor that they have sex among themselves and they got the problem. One may be a penetrative partner and another may be a recipient, mostly in the anus or in the oral things. So it is GOVA, genito-oral, anal can be there in the MSM. And we have to examine all the three places and find out what the disease they have. And we have to uh, not to teach or police them and say that they have to come out like that. It is none of our duty. Only thing is we should tell this is not natural, this is not required, and if they feel they should have with preventive tools, say condom, other things they have to use and protect themselves, both themselves and the partner. So we have to tell about the preventive aspect rather than correcting these behaviors. It has been found that it is very, very difficult to mm, correct them because so many of them they are not they chromosomal in nature, so it is very, very difficult. It is not and the child sexual abuse may be a cause for this MSM also. Or thing may be a cause child sexual abuse. So we have to correct these people or protect the thing by saying about good touch and bad touch. Perhaps I'll take one more class to teach how to teach the um, boys and girls about good touch and bad touch.
Thank you so much, sir, once again for explaining it really well, sir. I hope this will be very impactful to all the audience out there, sir. And thank you so much once again for sparing your precious time here. As I can see, sir, there is no more questions, sir. With all your permission, shall we conclude this session for today?
Right. See you.
Welcome, sir. Yeah, take care, sir, and hope to see you again in future also with different topics, sir. Have a